Next, we have the presentation from Myers Children's Hospital. Dr. Michaelangelo Tesi could not be here, so Dr. Francesco Peronel is going to be presenting on his behalf from Florence, Italy. The title is Cluster Analysis Unveils the Clinical Spectrum of Erdheim-Chester Disease.
So good morning, everyone. I'm here in place of Dr. Tesi, who is not able to be here, but I'm very pleased to present his work on this cluster analysis. And so we have no conflict of interest. And we all know that ECD is highly heterogeneous in terms of clinical manifestations. And so this makes the disease a perfect candidate for a cluster analysis because cluster analysis itself makes us able to identify characteristics and features of some subgroups of patients. And so we can identify subphenotypes of the disease and probably link it also to long-term outcomes or response to therapy. And so our aim was that, to identify subcategories of ECD patients. And to do so, we have taken 356 patients, the majority of which was taken from the pool of patients who underwent the GWAS study that was presented yesterday by Professor Vaglio. And we also added some other patients to this pool. And we performed a hierarchical cluster analysis that I'm going to show you how it works. So the cluster analysis is a very simple analysis in terms of what you have to do. You have to have a data set, you give it to the software, and you have no hypothesis, no testing to be done. It's the software that works, totally unbiased. And the software tries to aggregate patients in terms of characteristics that are similar or different. So identifying subgroup of patients who showed the similar characteristics. And the hierarchical clustering works like this. At the beginning, you have a number of clusters which equals the number of patients. So at the start of our analysis, we had 356 clusters. And as the software goes on working, it aggregates patients more and more. And if you let the job going and on, at the end, you could end up with a single clustering, which involves all the patients. And these are the data we used. These are very basic characteristics of patients. We had clinical manifestation at disease onset. And these, again, are very rough data. We had long bone involvement, perirenal involvement. We didn't have to put very specific characteristics. So, for instance, for long bone involvement, we did not insert it if it was upper limbs, lower limbs, symmetrical, asymmetrical. For perirenal involvement, we did not insert variables of clinical manifestations such as the occurrence of AKI, the need for urological intervention. And next to this clinical characteristic, we had also the mutational status of the patients, particularly in terms of BRAF and MAP2K1 mutations, and also the association with other hematological disorders, particularly LCH, Rosai-Dorfman disease, and MDS. So this is the first graphical display of the cluster analysis, and we were able to identify two models, one with 4 clusters and one with 5 clusters. And here you can see each patient is identified with a point, and each cluster is instead identified with a color. So this might be a little tricky because some cluster in this representation might overlap, and some patients could also be seen as very scattered, and so not they don't seem to fit into a group. But this depends only on the measures you use to outline the X and the Y scale, because of course this is not a bidimensional representation, and it is as many dimensions as many features you put in. And this one is the table where you could actually pick the characteristic that drives the formation of the clusters. And of course, I don't want you to go through this, but I just want to outline here that the clusters are not balanced one to another. So you have 4 clusters, you don't have 25% of patients in each cluster. You can have clusters that have very little number. Here you have 14 patients because they have probably a characteristic that makes this cluster very typical, very specific, And this cluster is next to others that have 150 patients almost. So this, of course, is the same table for the 5-cluster model. And these are the spider plots, which are another graphical representation of the cluster analysis. And how do you read them? So you have to see, of course, which is the characteristic that peaks within each cluster, but that's not only the thing you have to do, because for instance, for long bone involvement, you see it peaks in all the cluster because long bones are oftenly involved in ECD. So you could expect that every cluster has a high frequency of long bone involvement. But look at this, for instance, in BRAF mutation is very represented here, and you have very low frequency of BRAF mutation here and here. So you have to look at each feature among all the clusters to see the differences between them. And for instance, again, here you have a high frequency of digestive tract involvement, which is not seen in the other clusters. And here you have a high frequency of MAP2K1 mutations that is not seen in the other cluster, but I will go more further in detail after this. And this is again the spider plots from the model with 5 clusters. And I would stop here because I think this is the graphical representation that is easier to see, to read, and the one with the more intuitive explanation. So I will start with this cluster here, number 2 on the left, which is the model with 4 clusters, number 3 on the right, which is the model with 5 clusters, which is characterized by a very low frequency of BRAF mutations and a limited disease. You don't have any organ that is very frequently involved in this cluster. And it remains the same from the model with 4 to the model with 5 clusters. This second one is a cluster which is driven by a high frequency of digestive tract involvement symptoms and an association with other hematological disorders such as MDS. And again, this remains the same in the models with 5 clusters. And then we have this one, which is driven by a high frequency of MAP2K1 mutations and frequently testicular and lymph nodal involvement, which is again the same here in the model with 5 clusters. And then here we have the one we called the multisystemic disease, the widespread disease, because it's the most important characteristics is the BRAF mutation, which is very, very frequent in this cluster. And then you have many organs frequently involved: heart, large vessel, perirenal, CNS. And when you perform a cluster analysis and you observe the model with 5 clusters, this cluster gets split into, and you maintain the high frequency of BRAF mutations. And one has a high cardiovascular involvement with heart, large vessel, and associated to that, the perirenal involvement. The second cluster instead is driven by a high frequency of associated LCH with hypothalamic and pituitary involvement. So the features we are seeing here, which are here represented, are actually what we usually see in our clinical routine. And as you can see, there are 2 clusters with a very low number of patients. This one driven by a high frequency of MAP2K1 and lymph nodal and testicular involvement. This one associated with MDS. And other clusters that are bigger, one the limited disease with a low frequency of BRAF mutations, and the 2 with a high frequency of BRAF mutations, one with the cardiovascular perirenal involvement, and one with a high frequency of LCH with hypothalamic and pituitary involvement. And so to conclude, our cluster analysis actually demonstrated the presence of subphenotypes of the disease, and this is actually what we see in our clinical routine. So we identified a widespread multisystemic disease as opposite to a limited disease, and also subphenotypes which are often associated to other hematological disorders such as MDS and LCH. And I'm done, and I thank you for your attention.
Thank you for, is it on? Okay,
I can hear you.
you can hear me. Yeah, I can hear myself too. That's the problem. Um, thank you for your presentation. I think one of the challenges that we see in the clinics, especially at our place wherein we have multi-specialty practice here, I think recognizing ECD, the classic ones, is easier. But the challenge is the non-classical presentation. Did you have a chance to look into kind of like a single organ, let's say CNS only ECD, or I would say this would be rare, maybe even renal only ECD if that is in your data set or not. But did you kind of look into patients with no bone but kind of isolated organ, in particular maybe the CNS? That's a big challenge.
So you mean if when we analyzed the data set, we looked into patients who had only CNS involvement?
Yeah, something like that. I think, yeah, because if you have CNS only, it's not, ECD is rare in itself, but if you got brain and a long bone,
Yeah.
yeah, it's ECD. But if you got brain
Yeah.
only, it's hard to
understand the
think
question.
about ECD. Yeah.
I think I have to ask help here because yeah, because I know that for the analysis we don't go through the data set, so it's the software that makes it all. But I have to the confirmation of the diagnosis. You mean in a cases where only CNS was involved?
I think that can you hear me? I think the background question is different. So we have to put all this data together and see what happens. We cannot force the analysis towards the search for a given phenotype. Then if you're interested at seeing whether you have a given phenotype with only CNS plus bone, then you should do another type of analysis. And we can do that based on that data set, but that's not the question that we want to raise. Yeah, right. There's no cluster. But I think the good thing of this kind of analysis is that with an unbiased method, you have a subphenotyping which depicts some clear subphenotypes which we already knew, like the overlap with Rosai-Dorfman, the overlap with LCH. We have a sort of feeling that some patients with a BRAF positivity, they have a widespread disease, and the overlap with LCH is often BRAF positive. So all of these features are confirmed by this type of analysis, and I think that it really reconciles well the biology of the disease.
I'm going to ping pong off Ron's question, and this is broader than what we can discuss right now, but maybe it's time we really rethink about what we call ECD compared to other histiocytic diseases as we move into a molecular era and really think about how do we actually define these diseases. And I think the cluster analysis actually may help us help guide things that way.
I have just one question. So you're more convinced by the 4 cluster or the 5 cluster analysis?
I think that the 5 clusters were better because you identify the association with the LCH, which has a pituitary involvement, which is actually what we also see in clinical practice.
Okay. Very nice work.
Sorry, in interest of time, we'll keep moving, and we encourage afterward to maybe talk offline about questions if that's okay.